you know, obviously my specialty is lower extremity and feet, and podiatric medicine is a little bit different specialty than maybe others, because we treat an anatomic region of the body rather than an organ system. So unlike dermatology, it treats skin, or neurology, which treats nerves, or orthopedics, which are bones and joints, uh, we treat and manage a portion of the lower extremity. So, sometimes I'm a dermatologist, and sometimes I'm a radiologist, and sometimes I'm an orthopedist, and sometimes I'm an internist. And with as everyone else, we we have to deal with mental health issues, and sometimes we need to refer to your department for help in that. Uh, but every patient, in some respect, is a challenge. So, in any event, I'm going to show some of the things that affect not only just the feet, but the body as well, and how we can make a difference. It can be argued that the evolution from quadrupedalism to bipedalism is a approximate cause of the generation of civilization. Why is that? Because if you can stand up on your 2 feet, that frees up your hands, and if your hands are free, then you can create, you can make weapons, you can build things, you can show emotion, you can draw art. So much that you can do to build that you couldn't do if it wasn't that you could get around and stand on your 2 feet. And not too many species out there can do it. Certainly the humans, and a couple of marsupials, and birds are maybe in a different category. Certainly, they don't have the upper extremity hands that are freed, that perhaps other very few mammals do. So, in doing this, we are pretty unique. The foot evolved from a prehensile grasping structure that allowed our evolutionary ancestors to grasp and to ambulate in it. So, in a sense, the foot is an evolutionary advancement of the hand. The hand has not adapted quite as much as the foot has to support our need for bipedal locomotion. So, if you look at the foot structure of one of the great apes, I mean, the biggest, besides the development of the longitudinal arch, you see the migration of the first metatarsal here that goes from adaptability and flexibility to one of stability to support weight bearing and aid in propulsion to move the center of body forward. That's all that ambulation is moving the center of gravity forward without falling over on your nose. And the importance of feet is seen in everyday language. I mean, how many times have you used the expression, put our best foot forward, that we start off on the right foot? If you look at Egyptian hieroglyphics, you will always see nobility and royalty, usually from a side view, a lateral view. And if you see the right foot is forward, that is a sign that the person being depicted there was one of nobility or one of royalty. And right denotes from the Latin dextra, and the left side was believed to be the worst of the 2 sides, and the sinistra in Latin, where the derivation of the term sinister, which obviously doesn't have a good connotation to it. Other terminologies that are commonly used, we talk about cold feet, or put your foot down. You want to jump in with both feet and land on your feet, and we hold people's feet to the fire, and at the end of it, when it's all over, we are carried out feet first. In some cultures, the foot is an object of beauty when it is bound. This is not a congenital deformity. This is not. This is, in the truest sense, an acquired deformity, or an iatrogenic acquired deformity. In certain Asian cultures, a bound foot is the small of the foot is a thing of beauty to the culture. So this was something that was completely acquired through iatrogenic intervention, not medical intervention, but the foot being bound up into a little ball so as to shrink the size of it. And again, in certain cultures, this is a thing of beauty. In holistic medicine and complementary and alternative medicine, reflexology, the foot always plays prominent into it. I'm not, this is certainly something I'm not adept at or have much knowledge on, other than that the foot plays prominent. If anybody here has any experience in acupuncture meridians frequently involve areas of the foot. So the foot has lots of significance in complementary and alternative medicine. This is a nice quote that I show our new students, comes from almost 100 years ago, made by Elliot Jocelyn of the famed Jocelyn Diabetic Clinic up in Massachusetts at Mass General Hospital. And Dr. Jocelyn said, when patients consult you and uncover their feet, they little think that at the same time they lay bare their hands, their hearts, and their heads. The individual who cares for the cleanliness of his feet is careful about the condition of the rest of his body. The individual has good circulation in his feet, whose feet are neither cold nor blue, and possesses good muscular power, is likely to have a sound heart. We'll talk about the relationship later between peripheral arterial disease and coronary artery disease. Manifested if the arteries in the feet are healthy, there's a strong probability that those in the head are healthy too. When you treat the feet of a judge, you are able to conform an opinion of his efficiency on the bench. When you see the feet of a financier, you can form an opinion of his ability in finance. And only to the physician and the priest will the patient willingly show more his soul. A little pun on words there. So I don't need to tell you, you know this better than me about the graying, the silver tsunami, as we call it, in the country, and this obviously needs to be a little bit updated. But the graph continual is on the upswing. That we are an aging population, and with an aging population comes attendant psychological and physiological disease. So again, the tsunami of the baby boom is becoming gray. We'd like to say when we treat patients that there are 3 stages of life, that children and teenagers, they have got a ton of energy, they got time on their hands, but got no money. Adults have energy, money, and no time. And older people have time, they have money, but not necessarily any energy. So the same clinical condition in these 3 different age groups can be managed very differently. I like to tell the students that they should never treat a foot. They're always treating a patient with a foot problem. So we try to keep people functioning. It is important, as you well know in your specialty, that when people can no longer achieve their independence through physical, as the result of physical inactivity, when the proverbial take the car keys away from them, when they can no longer get out and be self-sufficient, the mind may be willing, but the flesh is weak, and that has a very deleterious effect on them in ways that you know a lot better than me. So the wheels of life, we like to keep them ambulatory and not get down to as you see in the bottom line. So with that in mind, the importance of it, just go over very quickly some of the common problems that we see and what are their clinical significance. Every profession, I like to say, has its CNC patients in podiatry, corn and callus, and dentistry. It could be cavities and cleanings. For internal medicine, it may be coughs and colds. Nothing terribly sexy or writing up a paper on it or exciting from that point of view. But to the patient, a hammertoe, a bunion, a callus on the bottom of the foot can make all the difference in their mobility. And this can prevent them from enjoying the creature comforts of everyday life. This is a quality life issue. People aren't gonna, this is not a critical medical emergency, but it certainly is a quality of life issue that can make people less mobile, keep them closer to home. And the last thing we need in the pandemic, I guess now as we emerge from the pandemic, is to have people who are less mobile on this. We are seeing patients who are, for good reason and obvious reason, were homebound. They weren't out. They didn't go to their doctor's appointments. So patients are starting to emerge from quarantine. And we're seeing these huge, thick calluses, these large, thick nails that have gone neglected for the better part of a year, if not exceeding a year. So corns and calluses, a corn is just a localized callus on the top of a toe. And these little things, if you don't think that can be disabling to a patient, I invite you to take a little pebble and tape it to your foot and try walking around for a day and see how that feels. If you had a pebble or a rock in your shoe, you don't get very far without kicking off your shoe and getting rid of the pebble. Just think of that pebble or that rock attached to your foot. Nail problems, again, we're seeing a lot of nails like this for people who have neglected them. People who have not had good care end up with paronychias. This is a extremely painful condition, inflamed toe. This patients generally end up either in our offices as an emergency, or frequently show up into the emergency room. The treatment of this is pretty dramatic in terms of relieving pain. It's just locally blocking the toe with a little local anesthetic and excising the nail margin of it, and then we'll frequently cauterize the matrix back over here, the nail root, with some phenol. Very archaic but very effective means, very inexpensive means of coagulating the matrix of the nail, and that becomes a permanent correction. So you look at aside from being a cosmetic problem, if this patient had associated immunocompromise, they could be HIV, they could be diabetic, they could have significant peripheral arterial disease, they could be neuropathic, and for some other means, this thick nail like that in the face of impaired circulation can end up in significant pain. These are fungal nails, and this partly due to environmental conditions. Fungus loves warm, dark, moist environments, so a shoe is a Garden of Eden to it, associated with other deformities. The toenails are actually just not there for cosmetic reason. They are a protective covering for the digit, and it's from a physiological point of view, they exert a counter pressure on the plantar skin and the pulp of the toes. There are baroreceptors there. The toes, the tip of the toes, are replete with nerve endings, not just sensory nerve endings, just not the small C fiber sensory nerve, but proprioceptive Pacinian corpuscles and proprioceptive nerve endings down there that help us recognize where we are in time and space. So this greatly helps the proprioception of the body, and in order for that to happen, you need a counter pressure on it, and that's probably what the main physiologic function of the toenail does in the human foot bipedal. The nail plate, it grows back from the matrix, and this is of significance to us for a couple of reasons. One is if it's aberrant, it can cause an incurvation or an ingrown toenail, but also you have melanocytes back in the matrix over here, particularly in patients of color. Longitudinal melanonychial streaks are common in the nail plate, and we need to differentiate that from just a typical melanonychial streak of no clinical significance other than cosmetic from a subungual acrolentidin melanoma. So that's a pretty important finding. Onychomycosis, fungal disease, is very common. You see this in patients, particularly the older you get. It's rare that a patient doesn't have some degree of it. In younger individuals, it is a cosmetic. In an older individual, it can be a painful affliction. And again, just take a rock. Some of those nails can be a centimeter and a half thick. and tape it to your toe and see how that feels. Most of these fungal nails are caused by dermatophytes, about 90% of them, a smaller percentage for yeast, and even a smaller percentage of non-dermatophyte moles and Nocardia species. But most of these are your typical dermatophyte T. rubrum, T. menticrophytes that occur in an approximate cause of garden variety athlete's foot. Prevalence of onychomycosis is 2 to 18% in the general population, much more common in the toenails than in the fingernails, and this increases with age. 50% of patients over age 70 will have some degree of mycotic nail environment. The risk factors, there's some genetic component of it. Age is a risk factor here. Repetitive nail trauma is it, presence of chronic diseases, circulatory diseases, diabetes, any patient who's immunosuppressed have it, whether it's primary immunosuppression or secondary, and pre-existing atopic or fungal disorders can precipitate this and set up the local environment where dermatophytes will thrive. Patients with hyperhidrosis, patients who sweat profusely are at increased risk for this occurring. This is a significant risk for bacterial cellulitis of the leg as well. And in the diabetic, that can result in gangrene and loss of limbs. So patients like this and the immunocompromised and the peripheral arterial disease patient are common. And this is the net result of it. A fungal nail like this in the diabetic or patient with a peripheral arterial disease is a not so uncommon cause of sepsis and gangrene of the toes. I have done many more TMA, transmetatarsal amputations, than I care to discuss in patients which resulted from thick nails that resulted in pressure points, ulceration, and development of gangrene in the toe. So this is a major problem in our patients, and the need, even though it's not sexy for students or residents to be involved in basic nail care, it really does have a profound effect on long-term well-being of the lower extremity. So the problem with onychomycosis, why it's so hard to treat, is that the fungus grows underneath the nail plate. So any topical medication which is placed on there is at best 12% effective. We like to look at this in terms of clinical cure and mycologic cure. Clinical cure implies that the nail plate is clear and clean. Mycological cure is that there is no residual dermatophyte that is on culture or on KOH or histopathology slides. The big thick nails, it's virtually impossible that a topical presentation of application of an antifungal will have any meaningful effect. There's several of late topical ones, the prescription-based, Jublier for one of them. These should be coming off patent soon, but for now, these are terribly expensive. You have a tough time, particularly in an older patient on a fixed income, to write them a prescription for something that's going to cost them $300 out of pocket, for that has maybe a 9 to a 12% efficacy rate on treating the nails. The most efficacious we have is oral, and right now the best one that we have is oral Lamisil or terbinafine, and even that at best studies is 60 to 70% efficacy on it. Lamisil is a safe medication, except in patients with pre-existing hepatic disease. So if and anybody that we're going to consider putting on this, it is a 3-month course daily, 250 milligrams once a day, as we're going to get baseline liver profile to make sure that there is no undiagnosed or unknown hepatic pathology. If that's not the case, this has proven to be a fairly safe medication. When it first came out, we would do a 6-week interval monitoring of hepatic function. The incidence of liver problems following starting of Lamisil is so exceedingly small that most people have abandoned 6-week monitoring of it. If you're good with your liver enzymes to start with, there's really no need to continue doing it. So deformed nails can have many other causes. Common things are common. We most normally think that it's going to be onychomycosis, and if you're a betting person, you're going to be right. Psoriasis, as you see here, can be a cause of pitting nails, repetitive microtrauma. So before we ever start a patient out on, certainly on oral therapy, we're going to get a nail culture to do a nail biopsy, get a specimen of it, and send it out to confirm the presence of onychomycosis. So things like yellow nail syndrome, lichen planus, a dermatologic condition, eczema, keratoderma, blenneragicum, or onychomycosis can all have a similar appearing presentations. And of course, unless you confirm it by histopathology, we don't start them on oral medications. The most common one would be PAS stain. You just get a sample of it, send it out, and look at it for the presence of the hyphae in it. The role of topical therapy, I mentioned, it is dubious at best, tends to be fairly expensive, and then for those thick nails, not particularly effective. There are several that are available, oral medications, Lamisil being the most common one that we use. And the reason why this is effective is that this works from the back, from the nail bed, and it's lipid soluble and it stays within the dermis even after cessation of the administration of it. So even though we do it for 90 days, it's efficacious for probably another 2 or 3 months. So what do patients need to know to reduce the rates of relapse or reinfection after we start on an encounter of it? Don't shave nail clippers. Do not wear shoes that fit well to avoid nail trauma. Do use antifungal sprays or powders in the shoes. Avoid going barefoot in public facilities. Throw away old shoes, and make sure that instruments are sterilized before going to a pedicurist or a manicurist in it. So if you're dealing with your patients and you're dealing with family caregivers or other caregivers, whether it be family or other ones, importance of good foot hygiene, particularly as it comes to the nail, is important to emphasize. Or referral to podiatric care for manage of this is in order. Other things that we see fairly common is hamatose on a daily occurrence. A hamatoe is a contraction, 2 joints, 3 bones in each toe, and when they get out of alignment, we refer to that as a hamatoe. There are varying shapes and varieties of it depending upon the joint contracture, whether it's at the distal interphalangeal joint, the proximal interphalangeal joint, whether the metatarsal phalangeal joint is rigid. Frequently, there will be in a geriatric patient atrophy of the plantar fat pad, which cushions the inferior surface of the metatarsal phalangeal joint, resulting in repetitive trauma to the plantar plate. This can atrophy and tear, resulting in disruption of the plantar plate and exacerbation of the hamatoe deformity. When you see this creates a retrograde force on the metatarsal, increased plantar loading, apropulsion of the toes, and in a patient who is insensate because of some sensory neuropathy, this is a major cause of plantar ulcerations in the foot. And even on the top of the toe, you wouldn't, this is a patient who everyone here has heard of. This is a celebrity patient who had a hamatoe and insisted on wearing tight-fitting shoes, to the point that the shoe caused an ulceration right through the skin, and resulted in osteomyelitis involving the phalanx. So what drives people here, this is more important to this patient who, I mean, certainly had a need to wear stylish shoes in the public light, in the public eye, but to allow this progression to it is something, I guess, your specialty can maybe shed some light on it, what drives people to think and do the things they do. But this is something that is not an everyday occurrence that I see, but it has happened more frequently than I care to talk about. Bunions. Bunions is a malposition of the first metatarsal. It is a medial deviation of it. It is not an overgrowth of it. Many patients just come in and say, there's a growth on the bone here. That's not the case. The case is the metatarsal has deviated because of hypermobility back in the midfoot. Some people believe that this is a genetic atavism going back to the prehensile grasping nature of the foot, in a sense that lurking in our DNA is some gorilla genes that were born with this. That's really not the case. I don't think modern geneticists ascribe to that theory, but there is clearly a biomechanical etiology here of instability where the cuneiform split, that there tends to be an obliquity of the metatarsal cuneiform joint such that the metatarsal deviates. The shoe will push the hallux or the great toe laterally, which results in this large bump here. There are varying degrees. No two bunions are the same, and you can see complete subluxation of it, not such bad deformity, but development of significant osteoarthritis. Bunion deformities certainly present a ambulation challenge to individuals who suffer from them. Finding shoes is difficult to wear. Improper fitting shoes are a major cause of falls, particularly in the elderly. And there is no non-surgical means that will make a bunion disappear. I can't prescribe a pill. I can't prescribe, put a rubber band around the foot or any type of treatment that's going to make the bunion go away, short of a surgical intervention on there. So when we're faced, doesn't mean every patient is a surgical candidate, and doesn't mean certainly that every patient should have surgery. So we need to either adapt the shoe gear to the foot or adapt the foot to the shoe gear, and at the same time manage the associated symptoms of it, pain, swelling, etc. So again, this is not a case where this is a growth. This is the metatarsal bone shifting medially, shifted over, underlapping the second toe. It's obvious the difficulty that this patient will have wearing shoes. When it is in combination with rheumatologic disease, this is a patient with severe rheumatoid arthritis that resulted in subluxation of all the joints. This patient could not walk from the living room couch to the bedroom without hobbling because of the severe pain that was on the plantar aspect of the foot. Through a variety of arthroplastic resections, we were able to realign the toe. It's not the most beautiful looking foot, but certainly something that took a exceedingly painful condition, and we were able to restore a fair degree of mobility. I mean, the patient's not going to run the marathon, but they certainly could ambulate and leave the house with significantly less discomfort. Here's another case, again, in a 68-year-old female who had a lot of things going on here. Not only the bunion, but had a brachymetatarsia deformity involving this has resulted in significant subluxation of the lesser toes. This patient had found it almost impossible to find a shoe gear, not only from a functional ambulational point of view. This created a psychological impact for this patient. She was stylish to a reasonable extent, and the thought of her just wearing sneakers or molded shoes for the rest of her life was abhorrent to her, and so she sought out a surgical cure. So in this particular case, we had to combine what what was feasible surgically with a functional foot. And in particular, this particular patient, she chose to have that this overlapping toe removed, which we did, and it's an option, even though the toe is not itself is not gangrenous, but she chose to do that. And we restored through fusion of the metcuneiform joint over here, removal of the toe. She was now able to fit this foot in stylish shoes. Now, she wasn't going to sit, around the side of a pool with this foot and show it off, but the ability to transform a foot like this that couldn't fit in any shoe to a foot like this that she was able to was transforming for this particular patient. Where you have osteoarthritis in the toe, as here, non-uniform narrowing, osteophyte over here, usually comes part and parcel with hip arthritis. So we're not just treating the foot. These patients also suffer, in many, if not most cases, from concomitant hip or knee arthritis. So they are candidates for multiple orthopedic interventions to restore their mobility. Osteoporosis of the foot is something that we see. Certainly, the osteoporosis in the foot is not as significant, creating morbidity as that which occurs in the spine, which is why, if you look at the family albums of someone, 30, 40 years ago, why they shrink is because of the spinal compression fractures. We do see osteoporosis in the foot. And when we see it in the foot, they do have a higher risk for stress fractures, for sure. So we caution them about shoe gear and activity level, and getting them fit with custom orthoses in the foot to spread out weight bearing of it. But also it's very important that we're sending these patients out for DEXA scans, if they haven't already, to see what the rest of the body is going, and referring them either to the females to the gynecologist or to their internist to institute treatment of the osteoporosis, and to lessen the chance that they're going to get vertebral compression fractures or fall and break a hip. And again, we see this as an important part of what we first identify in the foot, and then refer them back to their internist or other healthcare provider to manage the systemic disease. Arthritis of the big toe joint that limits motion is frequently referred to as hallux limitus, or decreasing the range of motion. This is a particularly painful condition because you can't propel body weight forward. It's important that the hallux be firmly planted on the ground, so that as the body weight moves forward, that you can propel around this joint. If this joint is arthritic to the point where you cannot propel body weight on it, you get breakdown. Not only does the joint become arthritic, but you get breakdown throughout the midfoot, and significantly will impact ambulation and enjoyment of life. We have a number of things that we do surgical. Usually this will result in a surgical fusion of the joint to do it. Although the surgical fusion decreases mobility significantly, it takes a joint that doesn't move, that hurts, and you convert it into a joint that doesn't move, that doesn't hurt. Other alternatives are to do varying degrees of joint replacement. 2-component, single component, double stemmed implants are all options that we have available to manage that. Not every big toe joint pain is gout. This is a patient that was sent to me by their internist, so a pain swelling about the first big toe joint, and that was translated into meaning gout. Pain, swelling, redness around the joint, and this was just an inflamed punctate keratoma that was on the bottom of the foot. But pain and swelling of gout has a fairly common presentation. Usually it's patients at risk on it, patients taking thiazide diuretics, patients with a history of hyperuricemia, hypertensive patients are all at great risk for gout. And usually the onset of gout is acute. It happens, this is the pain wakes them up in the middle of the night and does it. This is true gout, chronic Tophaceous gout, this is an advanced case. You can see all the urate crystals they had deposited in the tophus on the medial side of it, and significant erosion into the joint. So yeah, we treat a lot of patients with gout. There are some, pretty good anti-hyperuricemic medications that are now available. These are usually the purview of the internist. If we diagnose gout, we will work with the rheumatologist or the internist. So they manage the hyperuricemia, and us in podiatric medicine will manage the podiatric manifestations of it. When patients present with acute gout syndrome, I mean, it's like an acute kidney stone. I mean, they come in and they're screaming in pain, much like acute kidney stone patients do. Certainly, colchicine is one way to do it. Colchicine, is there's a little bit of a lag time there. It can result in significant GI distress. Certainly, NSAIDs, Indocin, and all the other NSAIDs that are classic prescribed for this can have GI side effects that certain patients with ulcers and other GI problems can't take them. One of the quickest ways to get these patients immediate relief is to do a little local field block with 3 cc's of xylocaine and inject then some insoluble steroid right into the joint. And you take a patient that came in agony, they get up out of the chair and want to kiss you on both cheeks because you have immediately alleviated their severe suffering. Other problems that are very common is heel pain. Plantar fasciitis and heel spur syndrome are particularly common. It's probably the #1 presenting complaint in a podiatric practice or outpatient clinic, and that's plantar fasciitis and heel pain. This has to deal again with a hypermobily unstable foot that increases on weight-bearing tension within the plantar fascia that actually pulls out some of the origin fibers on the inferior calcaneal tubercle, resulting in initially a periostitis and then calcification in this area. The hallmark of plantar fasciitis is that usually it's the first step out of bed in the morning, or if they're sitting in a chair, or they're sitting at their desk all day, and when they stand up, and that first step of the day is the absolute killer. With time, as one ambulates, the intrinsic muscles of the foot will reflexively go into spasm and splint the plantar fascia. So this actually, the more you walk on it, actually the better it feels on it. It's kind of paradoxical, but that's the case. This is what we'll do on these. Initial treatment to get immediate relief is again to inject a little anti-inflammatory medicine over there to put a strapping or an arch support in the shoe to take the tension out of the plantar fascia, and manage it with other anti-inflammatory modalities, topical ice, either topical or oral NSAIDs, and of course biomechanical control are important of it. So again, the plantar fascia is a fairly wide, broad-based ligament originating from the inferior calcaneal tubercles over here, and this is the region of the heel pain. We're seeing more and more of this. I think this is, I guess, where evolution, I left off on the other slide to get us to bipedalism, and this is particularly in a pandemic, how many patients have put on the so-called quarantine 15 in terms of weight. So this is the area of the pain. These spurs can be quite large, quite inflamed. The pain level is not necessarily correlates with the size of the spur. Sometimes the small ones can be just as painful as the big ones. Again, their insidious onset, pain upon arising, point tenderness at the medial tubercle. You can see dorsiflexion of the toes will make the plantar fascia here prominent. And if you press right in this location as the plantar fascia inserts on the medial tubercle, if it is an inflamed heel spur, you're going to be scraping the patient off the ceiling because they will say, how did you know to hit there? And that's pretty much diagnostic of what this condition is. If you look at a survey of geriatric patients, what are the predominant things that they present with? Bunions, hallux rigidus, hammer-toes, calluses, flat foot, cavus foot, all the things that I mentioned. These are the prevalence things which are in a geriatric population. Diabetes, we absolutely need to talk about diabetes because this is on the upswing. We live longer, we have a much greater incidence and prevalence of diabetes, particularly in third world medically underserved nations, and even in the United States we're seeing it. And I'd like to say that when the patient who has diabetes and immunocompromised and vascularly compromised, that if you ignore your feet, they're going to go away. So education is really important here. It's been shown in multiple studies that the causal pathways for foot ulceration, number one on the hit parade is neuropathy. You take the critical triad of sensory neuropathy, deformity, and trauma is present in at least 63%. If you add an ischemic component to that, that's only throwing gasoline on a fire. And the important thing is that, greater than 80% of ulcers are potentially preventable. It breaks my heart every time I have to do an amputation of a foot or part of the foot, or have to refer the patient for a below knee amputation in cases that could have been preventable. Remember, neuropathy, it comes in three varieties. You have sensory neuropathy. It's been said that God's great gift to mankind is pain, because pain is indicative of that something's wrong. And if you pay attention to it and go to it, you can probably intervene. The diabetic, the neuropathic diabetic, presents, can't feel it. So they have that toenail that is causing an ulcer, or they got that plantar callus that's causing an ulcer. They don't feel it, and next thing you know is they have an abscess or a wound in their foot and onset of gangrene. That's sensory neuropathy. Pain neuropathy, hypopathic conditions. These are patients, much less, probably only 15 to 20% of that will present with hyperesthesia. These are the patients that you see all the ads in the New York Times and in commercials and Time magazines that feed on fire, the ones that we prescribe, Neurontin or Cymbalta or Lyrica, to try to manage them. Far and above, the most common is a sensory neuropathy, where they have anesthesia of the foot. There is also a much neglected autonomic neuropathy that occurs. The autonomic neuropathy in the foot affects the sweat glands, the apocrine sweat glands on the plantar aspect of the foot, so you get dry, callous, cracked skin. It also affects cross colonization in tendons. The joint capsule and the Achilles tendon gets inelastic, resulting in decreased flexibility of the joint and formation of deformity. So lots of things that go on in the foot. This is what we want to avoid, a neurotrophic ulcer. Okay, and you can tell this is neurotrophic as opposed to ischemic is if you look at these and you see the pink granulation tissue. This is not an ischemic. Well, there's probably some component of the decrease, but this is primarily a neurotrophic sensory-derived ulceration. If this gets infected, it gets bone infection, you can end up with loss of parts. You go into a transmetatarsal amputation. The transmetatarsal amputation ends up, again, because of the sensory neuropathy, of breaking down. And before you know it, you end up with a below-knee amputation. These type of things, for the most part, are preventable. Every 30 seconds, a lower limb is lost somewhere in the world as a consequence of diabetes, and this is the type of things that we try to prevent. If you look at the relative 5-year mortality rates of a patient with PAD or Charcot foot who develops an ulcer, it's approaching 50%. And that's a scary thing. In fact, the 5-year mortality rate of a Charcot foot or a PAD patient certainly vastly surpasses prostate cancer, Hodgkin's, breast cancer, and really the ones that surpass it, lung cancer, pancreatic cancer. But you get an amputation in there. Someone has a BKA, 68% of them are dead within 5 years. So that's pretty sobering statistics there, and all the more reason why we want to manage these patients and their comorbidities and to keep them ambulating. Okay, so you can see that you know the 5-year probability of a major amputation is in excess of 50%. Now, wound management. Not all ulcerations that we see on the foot are a sign of diabetes or peripheral arterial disease. This is your classic ischemic ulceration, dried necrotic skin, so-called dry gangrene. Contrast that with a neurotrophic ulceration, where once again you see the pink granulation tissue. This will heal. And we'll talk a little bit more about that. Get close to the end here to finish up. But neurotrophic ulcerations are predominantly on the plantar aspect or in areas of pressure, shearing pressure or direct pressure. Venous ulcers tend to be up on the medial side of the ankle. So when you see an ulcer like this, and it's on the medial side, you think that more of a venous. Other reasons of it. This is an embolic. This is a patient who came in with this ulceration. Wasn't diabetic, didn't have PAD, had bounding pulses, wasn't neurotrophic. So everything has a reason for it. And then this was a sudden onset. It started out with a pain and developed and progressed into an ulceration of the toe. And feeling his pulse, I found immediately a very irregular pulse. The bottom line is this patient had Afib and had an embolic phenomena from the valves. This could have easily went to a major clot, could have went north and ended up in the brain, and this patient could have had a major stroke. Instead, it was having microemboli that went south into the foot. And fortunately, he was heretofore undiagnosed with atrial fib and got to the cardiologist, and his atrial fib was managed and placed on the proper anticoagulants. Here's another patient that was sent in by an internist, pre-diabetic, 60-something years old at the time, said pre-diabetic ulceration on the foot, therefore this must be neurotrophic, it must be a diabetic ulceration. Examination of this foot found bounding pulses, no neuropathy. This was actually kind of tended to it. The reason why this lady had an ulcer there had nothing to do with her pre-diabetes. This was a melanoma. This was an amelanotic melanoma. Fortunately, we were able to do a resection, get her into the oncologist. She was managed medically, and she's still after 5 years doing okay. She recently, in the last couple of months, ended up with a liver metastasis from this. So I'm not quite sure whether they're going to do a metasectomy of the liver lobe on her. But the point here is ulcers are a varying of it. An acute wound is different than a chronic wound. In acute wounds, they have a very high mitogenic activity. They have very low inflammatory cytokines, low proteases, and the cells are not senescent. When a wound converts from an acute to a chronic wound, the cells lose their ability to divide. Very high inflammatory cytokines, very high metal metalloproteases that are present there that inhibit wound repair. The cells kind of just become very senescent. So this is what we have to evaluate when we're dealing with wounds in wound care clinics to differentiate, and we try to convert a chronic wound into an acute wound. Wound care is getting pretty advanced, lots of adjuncts, but the basics of good wound care, proper medical management. The patient's hypoglycemic, they got to be managed. If they're malnutrition, they need to be managed. If they have renal failure, that needs to be managed. The patient needs to, if they have vascular disease, we need to identify that and get them to our vascular colleagues so that there can be some intervention. Identify the presence of neuropathy, although that's not something that is generally treatable per se directly, but managing the high cholesterol and blood pressure and hyperglycemia by the internist doing that can certainly help keep it in check. We like to say that in wound care on the foot, it's not what you put on the wound, it's what you take off. And what is it we're taking off? Pressure. So we offload the deformity. And the other thing we take off is necrotic tissue, so we debride. So debridement of these and offloading of it is critical. And then, of course, working in conjunction with ID to manage infection. Screening tests that is done in any podiatric clinic or is very simple that can be done chairside. Palpation of pulses, cap fill time, very easy to palpate the pulse. Doing a simple percussion of the tip of the toe for cap fill time, doing bedside, chairside Doppler examinations, looking at an ABI is quite telling. The ABI test is a very easy to do, it's an inexpensive test to get, and can be quite telling into what's going on. In screening for neuropathy, we do vibratory testing, looking for ankle reflex, light touch with a Sims-Weinstein filament. If we want to get a little bit more sophisticated, we can do special staining. We do a punch biopsy right above the lateral malleolus for staining. Then send it out. You have to do a derm path lab that is equipped to do this testing, but staining for a quantitative analysis of small C fibers can help quantify the presence of neuropathy. I mentioned already, it's not what you take, not what you put on a wound, it's what you take off. Bioburden is an important role here, taking off this fibrotic tissue around here, debriding off of this fibrous tissue. Underneath there, you can see bright granulation tissue. So debridements are really important to get down to good bleeding tissue. We like to do pre-ulceration force plate. We can look at and do computerized gait testing to look at areas which are loading in the foot. These are sensors that are placed on the foot. It's not a static, this is dynamic foot pressure, and we can look for varying areas and offload those before the development of an ulceration. So in terms of offloading, we do need to use ingenuity sometimes, very simple, a felt pad on the foot, a variety of shoes and offloading devices that can be done. But all of these things is taking pressure off of the area on it. Surgical offloading sometimes we'll do to remove pressure points, take the patient to the operating room, and then we move to advanced wound care technologies. The rule of thumb that we tend to use is that a wound with good, proper wound care should heal by 50% in 4 to 6 weeks. If after 4 to 6 weeks we find that the wound is not healed. Now, these patients are depressed. These patients, for lots of reasons, they have other comorbidities, their increased morbidity, their mobility is impaired, and they are frequently depressed. And so we need to have mental health consults to help these patients through their depression and to stress the importance of offloading it. There is lots of data that shows that interdisciplinary care is the best care here, and certainly in management of diabetic wounds. Wrapping up, I'd like to say that feet can say a lot about your heart. The presence of PAD is usually a marker for CAD. I do a fair amount of referrals to cardiology when I identify patients with significant PAD, and not uncommonly after cardiac workup that they're found to have significant coronary artery disease or carotid disease. So these things go hand in hand, or foot to foot, if you want to see. Again, we know the survival of patients with a peripheral arterial disease is low. I mean, if you take someone with a critical limb ischemia, they have a critical limb ischemia, gangrenous wound, or severe claudication, tissue loss. their 5-year survival rate or 10-year survival rate is about 5%. So these are sick people, and interventions and identifications early on can do a lot to do it. The ABI, which I mentioned before, is actually correlates very nicely with the Framingham risk score to predict cardiovascular events and mortality. Hence, when we identify patients with PAD, we get cardiac consultations on it. I mentioned before about the patient presented with the embolism, Afib. This is a common condition, not uncommonly we're the first to identify it in the foot. Certainly the patient we saw before, his emboli went distally, but certainly could have went north up into the brain. We see from time to time Janeway regions. These are little necrotic plaques. These are associated with bacterial endocarditis, and they result not from thrombus, but from septic emboli, microemboli, as a result of the endocarditis. Oslinodes are a variation of the Janeway lesions, except that they are raised cutaneous nerve. We saw actually a fair amount of these during COVID. These have been referred to as COVID toes. So not an insignificant of little vasculitis lesions that have been occurring in the toes. Pressure ulcers, not so much ambulatory patients, but in acute in patients who are hospitalized or patients at chronic care facilities develop on the heel. So when we do podiatric consults on inpatients and in extended care facilities, we're certainly recommending that the heels be offloaded. And of course, not necessarily podiatry, but the rest of the body needs to be offloaded. Pressure ulcers have a very high morbidity and cost. We want to keep people going. The Gait Cycle, I like to use this. You may recognize this as the cover from the Abbey Road Beatles thing. That they didn't mention it, but this is a dramatic of the Gait Cycle from heel strike to flat foot to toe off on it. Normal changes of gait in the aging individual slows down. You will notice decreased stride length and arm swing, forward flexion at the head and the torso, and increased lateral sway. Foot problems impair balance and are a great risk for fall. So a lot of those things that we talked about, bunions and hammer toes and neuropathies and weaknesses of the toes and limited mobility of a joint, are a really proximate cause of trips and falls. And you know, and we all know, when someone breaks the hip, that the morbidity associated not so much from the fracture, but the pneumonias that follow and the immobility, the psychological depression is a major health concern. So 30% of those over 65 fall annually. Half are repeat fallers. Falls go up with each decade of life, and many in nursing homes and hospitals will fall each year. We like to evaluate patients for fall risk factors, and that goes to comorbidities. Eyesight, can they see their foot? Can they view? We ask them about their home, their house. Do they have throw rugs? We talk to their caregivers, their family, so that they have a safe environment that will prevent falls. Older people, fixed incomes, can't afford good quality shoes. It's not uncommon. They come in with shoes that look like this. This is a fall waiting to happen. So we're not just looking at the feet, we're looking at the shoes. I mentioned before melanomas in a few cases. We're certainly doing skin. Acrolentidin melanoma is a disease classically in sun-exposed areas in light-skinned people. Not so on the foot. And the foot, acrolentidin melanoma is much more frequently seen in dark-skinned people, people of color. It's a different animal than what we see on the rest of the body. We see every year in our clinic maybe half a dozen or more melanomas, some of them quite advanced. When they come in, it looks like this. It's an acrolentidin variety, which not only the location of it, the nuclei and the form, the histology of these is a little bit different. I mentioned before melanonychial streaks. If you're looking at someone's nail and you see pigment spill over into the nail margin or the nail root. That's referred to as Hutchinson's sign, and that is a hallmark for that this may not be a subungual, just a classic nevus or melanonychial streak. It is more commonly associated with a melanoma or an acrolentidin melanoma. Posterior tibial tendon. Posterior tibial tendon comes down behind the malleolus and is the prime supinator of the foot and inverter. Geriatric patients frequently have an atrophy, a fraying of the posterior tibial tendon that results in a frequent collapse of the arch. And again, aside from being painful, this can inhibit gait and present a fall risk of it. So in some cases, we will do a surgical repair of it. In advanced cases, it may require a fusion, hindfoot or an ankle fusion. And in patients who are not operative candidates, we do bracing to keep them stable. So again, I know it's getting late. We do, and where surgery is not indicated, alternatives to high top boots and foot orthoses for PTTD is there are a variety of braces that we will get a patient in, and Arizona braces a particularly good, effective one that's relatively easy for people to use and to keep them functional. So I'd like to tell, again, as I said before, patients never treat a foot. Treat patients with foot problems because there is a lot going on north of the ankle. While we are predominantly as podiatrists licensed to treat just the foot and the ankle, we identified lots of disease that is there and make the appropriate referrals out, and not the least of which is to mental health and to psychiatry, because these patients are frequently depressed and they do need your good care as well to keep them as functional as possible. So I took a lot of your time out. I appreciate you doing it. If there's anybody has any immediate questions, I'd be happy to answer them.